So welcome everyone to today's webinar, which is covering the health assessments for clinicians. So as Julie said, my name is Jane Cooper. I'm part of the practice support team and I'll be hosting today. So I'd like to first start by acknowledging the traditional custodians of the lands on which we meet today and pay my respects to the elders past, present and future. I extend my respect to the Aboriginal or Torres Strait Islander people who are present today. So I'm just letting everybody know that today's session, the attendees will be muted so we don't have any background noise, and we will be recording the session that you'll have access to later. During the presentation, if you have any questions, please feel free to pop them in the chat pane, and if time permitting, we will answer them at the end of the webinar. So just to let you know, there is a total of 4 MBS webinar sessions for clinicians being delivered over the next 2 months. So we have had Medicare and chronic disease management, care plans reviews and home medicines reviews, and today's session, which is on health assessments. We do have cycles of care coming up on the June 22nd, and then that's followed by the final series, which is CDM Plus Insights with a question and answers session incorporated in that. So these webinars are part of support activities that Country SAPHN have been able to fund for general practices. And as I said, the sessions are being recorded and will be available on our Health Connections community platform at the conclusion of the webinars. So today we'll be talking about health assessments, and we have Jane Kologeros, owner and lead consultant of CDM Plus, who is going to be delivering the webinar content today. Jane has had 22 years of nursing experience and the last 7 years working in general practice. Jane began her nursing career in the year 2000 after completing her Bachelor of Nursing in Newcastle. Jane's unique nursing background and knowledge of funding mechanisms, Medicare item number requirements is a valuable resource for general practice and continues to make CDM Plus leaders in their field. So welcome, Jane, and over to you.
Thanks, Julie and Jane. We'll just kick off straight away. There's a lot of, I guess, content in this session, and if we've got time, I'll go through some additional resources and some extra things in the clinical software. Any questions, just pop them into the chat as we go along, and we should have enough time for a few questions at the end of the session as well. So learning objectives to identify the CDM MBS item numbers and to apply that learning. So we do training a lot with chronic disease management specifically, but the health assessments always seems to be a really big topic. And I guess one of the reasons why is there's like 11, I guess, different Medicare health assessments that are available. So I like to look at it from, I guess, the bigger picture. And I think for myself, like the process for a care plan and a health assessment are quite similar. So I'll show you on this next slide, I guess, just an overview of what both those appointment types are like. So the information we gather, the actual process of getting the patient in, like checking their eligibility, using those text shortcuts, and then those details we're collecting as part of that appointment. And the usual differences are just that the documents are a little bit different. Medicare's got different requirements as well. So I guess the whole aim with any health assessment that we're doing, regardless of the name that Medicare, I guess, has given it, is, you know, to identify those potential risk factors for patients getting a chronic condition or complications from existing conditions. So looking at things like their age and gender and family history, and then other things around lifestyle, so smoking, etc. as well, and reducing those biomedical risk factors. So all of that, once we get to the end of that and making that big list of things that we can do with the patient over the next 12 months, we need to actually put that into a plan for the patient in a way that they can, I guess, use and, you know, to ultimately reduce their risk factors. So we're going to break it down bit by bit. I've got a couple of flow charts that you'll also have access to as well after this session. So let's start with the three main types of health assessments. So we've got the Aboriginal and Torres Strait Islanders health assessment, and I'll go through this more in detail with the flowchart because it'll make a little bit more sense. We've got the time-based health assessment. So there's 4 item numbers and 7 different types of health assessments in that category. And then we've got the heart health check. Now, this originally came out as a temporary MBS item number, and it's still in place. And I think they're looking to review that towards the end of the financial year next year. So it'd be interesting to see if that stays as a permanent number from there. Within the 715 health checks, we've got 3 different age groups as well. So I guess there's a lot of things to consider in, I guess, which health assessment we're going to be targeting for the different patients. So as an example, with the Aboriginal and Torres Strait Islander patients, we're not going to get a rejection if we bill a 707, but you won't be able to do a 715 for 12 months, as an example. So I've got a flow chart that is specifically looking at what's best for the patient and for the clinic financially. Now, the MBS items are quite varied in the financial amount that comes back. So as an example, the 699 is only $75.75. The 715 is $220.85. And the 701, 3, 5, and 7 are time-based. So the lowest one, 701, is $61.75. The 707 goes to $279.70. So there's a lot of things to consider. The time-based have a lot of criteria around them, and they all have different frequencies as well. So like all things chronic disease management, I like to start with a plan. Okay, so the first top tip when we're looking at health assessments is to actually start and have a look at your data, because a lot of clinics have, thousands of patients, and without breaking that down a little bit, we're going to get a little bit lost of which health assessment to do and what's our process going to be. So we don't want the clinic to be overwhelmed. We want to work this into our everyday, I guess, CDM activities that we want to do with the care plans and reviews. So reports and data. So looking at your patient demographics, what does that look like? How many patients are over the age of 75? How many patients identify as Aboriginal and Torres Strait Islander? Does your clinic service any residential aged care facilities? How are we going to try and target, specific groups? So also have a look at the reports. So the financial reports of what item numbers have been billed. What's your most popular item number that you currently like doing? From the training that we do with the clinics, the majority of mainstream clinics, the 75 plus is the most common health assessment. And for the Aboriginal Medical Services, that 715 is always the first, I guess, entry point into the chronic disease management and prevention detection activity cycles. So the data is very important. It's also important to measure, I guess, once we start this activity. So one of the things to consider is, like, obviously we're not going to be able to launch out and do all of these 11 health checks all at the same time with our whole practice population. Okay, a lot of these things will depend on how many resources your clinics have. So how many nurses, how many health workers, how many GPs. And I guess, I like to target different health assessments, different times of the year. Especially for some of the different age groups. And we'll talk about that as we go through. But I like to match some things up with the preventative health calendars and days. So, diabetes week and, heart week and that kind of thing, because it helps, I guess, to line up with some of those messages that are already coming out through the news and social media as well. So we'll talk about those as we go through. Some of the challenges that clinics always talk to me about are getting that 40 to 49 and 45 to 49-year-old age group into the clinic. And that's a really tricky one as well. So that's where it becomes a really good plan to look at your demographics and then just figure out when we're going to target these specific groups. So the planning part is, I guess, one of the most important, and it will determine our next steps. So let's look at this little flow chart. I've kind of put the numbers against this little flow chart just to help break down which health assessment to do. So up at number 1, we've got, does the patient identify as Aboriginal or Torres Strait Islander? If the answer is yes, it's always going to be that top pathway. So it's always going to be the 715 health assessment, and there's a couple of reasons. So for the Aboriginal Medical Services, it's linked, that item number in particular is linked to funding and reporting and follow-up. So there's 5 individual allied health services available as part of that health check as a once it's been billed. And then there's also the follow-up 10987 items available as well. So it's a really, I guess, complete pathway for the patient journey through that cycle. So it's always going to be that option. And it's not that we're not going to work in, you know, cardiovascular risk or anything like that. We're going to work that into whichever, we're going to work in the preventative and early detection activities as part of any health check. So it's not going to be like specifically just one thing we're targeting in a health assessment. It's that overall picture. So if the patient does not identify as Aboriginal or Torres Strait Islander, we've got 2 options. We can try and do a time-based health assessment. And if the patient doesn't meet the criteria or they've already had one, then we're going to see if they meet the criteria for the heart health check. Now, the reason that the heart health check is last is not because I don't want to do the cardiovascular risk and that heart health, you know, check and prevention, but the financial amount is quite different for the clinic. So as we said, the heart health assessment, $75.75. So if possible, then we're going to try and do one of the time-based. Now, something to think about as we go along, because each of these health assessment types has a frequency. So as an example, for the 715s, we can do these every 9 months. So that's a really nice regular preventative health appointment that we can line up for patients each year. And I think that's a great pathway. For the other 2 health checks, it just depends on the actual health assessment that's been completed. So as an example, the 40 to 49 is a once every 3 years. 45 to 49s are once only. Over 75s every 12 months. So a lot of these ones in the time-based, I guess, a bit trickier to line up a regular assessment. But if we take a step back and think about the time-based and the heart health check, I guess, together, because the heart health assessment we can now do from age 30 and over, if we kind of look at it from that perspective, we can really almost line up a health assessment for the patient every 12 months. So if we started at age 30, then we could actually kind of work our way through and rebook that patient for a heart health assessment. And then obviously if they get to 39, we could try and line up the 40 to 49 if they meet the criteria. So we'll talk about that a little bit more, but I just wanted you to think about that as we go along. So it just depends on where the patient's at, which health assessment they've had before. So it's just good to kind of work through that flow chart if you're unsure. Okay, so second top tip is to actually define the process. Okay, how long are those appointments going to be for the health assessments? Are you going to have different appointment lengths for the different types? So as an example, a 40 to 49 versus a, you know, over 75 health assessment, are these going to be, you know, different lengths? And checking the eligibility and that, I guess, before and after appointment workflow for the patient, what does that look like? And then documentation. So it'll come down to a lot of the documentation of the eligibility and the documentation of the actual assessment as well. The billing and reminder process, what is that going to look like for patients, and will you, I guess, implement that process of booking the next appointment? So that's another couple of things to look at, but I guess the basics of that is who does what when is the really, I guess, quick definition of that one. I like to split things into clinical and admin tasks just to make it a little bit easier on the team, and then everyone's quite clear of who needs to do what as well. So getting feedback from your practice team before kind of, you know, jumping into a project is really helpful, because you're taking into consideration things that you might not have thought of. So looking at these things, you know, before, during and after, like getting feedback from your team is a really important part of, I guess, trying to implement a long-term process. Let's look at the 715 health checks to start with. So I've got some links to, I guess, the full descriptors for each of these health assessment age groups. So let me just go. So first slide, we're just going to look at the 3 separate age groups. So the 715 item number, it's the same item number, but there's 3 different age groups. So 0 to 14, 15 to 54, and over 55. So I've got some, I guess, little top tips for each of these as well. So I'll go through these as we go along. And I guess the first bit is that these health assessments can be done every 9 months. It's really one that I really like to book the next appointment when the patient's there. And depending on the age group, we'll also book the follow-up appointment, especially if there's bloods or, you know, further screening that we need to do as well. So this pathway is also usually the first point of contact that patients might have in the Aboriginal Medical Service, especially coming through. And that pathway usually works a little bit differently to the mainstream. So usually for that 715, it's the first point of contact. If the patient has a chronic condition, then we might book them in for the care plan review, depending on where they're up to in that pathway, or if that pathway hasn't started yet. So I guess it's a really first point of contact for a lot of patients. So for that first age group, because that 0 to 14, it's a really big age group. Some of the links that I've got in the sources and more info today is to the RACGP and NACHO templates that were released. There's some really great information, and they've actually split these age groups down into 5 age groups. But just keep in mind, you're still going to need to meet the Medicare requirements for these specific health checks. Okay, so my top child tips for this one is to actually try and line up for the, I guess, the very brand new babies starting from naught, is to line up that first 715 with the 6-week immunisations. I found that a lot of that information was, I guess, overlapping with what we're doing in the 6-week check. And so a lot of the Aboriginal medical services that I've worked in, we're actually lining those 2 appointments up together. And then because we can do these every 9 months, we actually line up the second 715 with the 12-month immunisations. The GPs also had that option for the, I guess, the plus or minus of the 23, depending on the circumstances as well, to that appointment. With the kids, I guess in the older, as we get a little bit older, knowing and I guess accessing those pathways, specifically for vision, hearing and dental. And obviously depending on where you're working and areas and, you know, access to services, it can be a little bit difficult. I guess the main age groups I usually found, you know, that under 5, it was really tricky sometimes to get services, especially for hearing. So if you don't know what those pathways are for your clinic yet, like it's probably worth just finding out your, I guess, closest services and any out-of-pocket costs. And we'll talk about that more a little bit with the allied health. So for the adult age group, I guess the top tips for those in the MBS requirements, they've specifically mentioned urinalysis and the visual acuity in there. So I usually try and do that as part of any health assessment, as just a routine thing, but they specifically mention it in this health check. So for the 15 and 54. The other, I guess, thing to consider with this age group is that the patients are at risk for every single chronic condition. It's such a wide age group to kind of look at. So a couple of clinics will do this differently. Some clinics from age 30 will automatically add an ECG as part of this appointment. And we would usually, you know, automatically book the follow-up appointment to go through the blood results and any other screening we needed to do as part of that health check. So it's just worth, I guess, identifying what that appointment workflow will look like for this adult and older adult age group as well. So those follow-up numbers come in quite handy when we're kind of making a list of all the things that we need to do over that next, 9 to 12 months, before we see the patient again. So a lot of those are preventative, appointments. It might be something like an immunisation as an example. Okay. The other, the 10987. So I've already said that one. The older adult top tips. For those that haven't done this one before, but have done the over 75 health check, the descriptors are actually identical, just worded a little bit differently, but identical. So for this age group, I guess a lot of what we're looking at is a lot of support services. So identifying what support services are needed, if the patient qualifies for any, particular funding, and then referrals. So a lot of referrals in this age group as well. So a lot of people will say, but why are we doing this and the patient's only 55 when they're kind of comparing descriptions to the over 75 for the non-Indigenous patients. So I guess what you have to consider is a lot of Aboriginal and Torres Strait Islander patients are actually diagnosed with multiple conditions before they're 40. So when we get into this age group, we're starting to see, I guess, some complications and the need for some of those support services, I guess, coming from these health checks. So those allied health visits that I guess are part of this referral pathway make it, I guess, really easy for that access for allied health. And we'll talk about the pathways for the different allied health providers as well as part of this one. So that 10987 number will also come in very handy for the follow-ups for these patients. So as an example, if there was one of the things identified, it might have been, the need for continence products or something like that. If the patient, you think they'd qualify for some of those funding, it's usually paperwork. So that combination of paperwork appointments is usually split between the nurse or health worker and GP, or some clinics it's just the GP. So that's something to consider in that particular health assessment and the over 75 as well. So I just want to show you the allied health pathway, and I guess part of it today, because we're actually talking about the 715 health check. When we spoke about the care plans, there's also that referral pathway. So these are the three very specific pathways with different forms that you'll need. And the first one is obviously if the patient has a chronic condition with a care plan and the team care arrangement, they get the 5 allied health. The one we're talking about today will be if the patient identifies as Aboriginal and Torres Strait Islander and they've had a health assessment. So you'll notice on that form, if you haven't before, it's actually got the time-based numbers and the 715 listed. So if the patient is in a residential aged care facility, the health assessment will actually be one of the time-based numbers and not the 715, if that makes sense. So it's just to kind of tick which assessment has been completed. So for those just in the, I guess, general practice, Aboriginal Medical Service completing it with the patient, it will be the 715. For those GPs that are servicing the residential aged care facility, you'll be ticking one of the time-based numbers. So if the patient has had a health check and they have a chronic condition, they can actually get 5 referrals under one form and 5 under the other pathway for the care plan and TCA if that's in place. It's worth mentioning in this session, and we'll, I guess, mention it in the diabetes cycle session as well. If the patient has type 2 diabetes, there's also group allied health visits that are available as well. They only need the GP management plan in place to access that one. Okay. So while we're looking at, I guess, some of these pathways, because some of the things we're going to identify, especially if we're starting to do health assessments on patients in those younger age group, is the need for some of those allied health services. So it might be through one of these pathways, or you might be, I guess, referring or helping patients to book into other pathways that might incur a cost. So I usually track I guess, any out-of-pocket costs for the patient in the address book. So while we're on this screen, I might just show you quickly in best practice as an example. So up in the address book, over. So as an example, like exercise physiologists, if we were looking to see who we could send the patient to, in the comments section, I usually document the date. So if I've rung up to find out, how much it is out of pocket, I'll actually put the date, whether they do individual or group sessions, and if they have any out of pocket costs. Okay, so that's for any allied health or, whoever you'd be sending patients to, even if it's like a lifestyle modification program outside of the clinic that might not be through an EPC. And I also do the same for any other ones. So, when we're talking about some of the younger patients that we need to send for vision and hearing, just keeping track of which providers see those age groups can make it a bit easier to decide. So one of the other reasons I like to do this is to actually give the patient some options. So if we're looking at I guess helping them get into some allied health as a preventative thing, then we need to help them decide and so they know what those costs are going to be. So I don't want to send them somewhere and then they go to make that appointment and find that, they're going to be out of pocket, a certain amount of money. So I try to offer them a couple of options. So it might be that, this one through the hospital is bulk billed as an example to go see the dietitian, and the wait time's about 6 weeks, or you can go see the one down the road and it's $15 out of pocket each time you see them, and if there's any other options. So that way the patient's informed, they're actually more likely to turn up if they actually choose that provider as well. So it's just about reducing those barriers if we are going to send some referrals out. So if the patient doesn't identify as Aboriginal and Torres Strait Islander, then we're going to look at these two other options now. So let's look at the time-based health assessments. And one of the things I just wanted to talk about was there's actually been a little bit of a change in the, I guess, description of the item numbers. So we're going to have a look at that bit first and then talk about some of those other health assessments. So the time-based health assessments, the reason we call them that is it actually counts the nurse or health worker time and the GP time together. Having said that, a couple of years ago, they kind of tweaked the little descriptions of these item numbers. So for those that have been around a long time, we used to just add up the kind of nurse and doctor time and just, if it was myself and the GP each 30 minutes, then we would say, 60 minutes, it's automatically a 707. So I think if you're looking at starting to do a lot of these assessments, maybe just have a little read of the descriptors and any requirements. And I've got the links there for all the different types of assessments as well. So you can go through the presentation and actually just have a little read on Medicare of some of those as well. But the 701 that you can see, it's classed as a simple health assessment. The 703 is a straightforward assessment. So you can see there that they've actually still got the time listed with each of these items, but they've also listed, I guess, a complexity. So the 703, they're saying that the patient does not present with complex health issues. The 705 as an extensive assessment and that the patient has a range of health issues. And then the prolonged, like the 707, is for a complex assessment and the patient has significant long-term health needs. So it's, I guess, not just the time anymore. I guess we have to make sure that we meet those additional descriptors as well. So it might be worth just looking at those links that I've got there. I'll take you through the extra writing that Medicare has there as well. So the GPs might want to use that part as their text shortcut and leave the other main description, like the text shortcuts for the nurses to use as part of theirs. So this is the list of the 7 types of time-based assessments. And with the clinics I work with every day, honestly, most clinics will say they're over 75 in these time-based assessments. And I guess there's a reason for it, isn't it? Like a lot of these patients have existing chronic conditions, so they're usually in and out of the clinic quite frequently. So it's quite easy to, approach those patients and get them rebooked. It's a really good health assessment to rebook. So a lot of these patients are used to that process, especially rebooking with their specialist appointments and any allied health. So booking them 12 months in advance is not anything new to them. So it's a really great way to just get them into that rhythm of every 12 months. The 40 to 49 and 45 to 49, when you actually look at those descriptions, and we'll go through those if we have time at the end of this session in a little bit more detail, but both of these are kind of looking at the same thing. So they're looking at the patient's existing risk factors. They're looking at the patient's family history. But for the 40 to 49 at high risk of diabetes, we actually need to make sure that we've completed the AusRisk tool at least within 3 months of completing this assessment. So that's, I guess, a part of that one. The 45 to 49 for patients at risk of a chronic condition. So same thing, we're looking at risk factors, family history, and reducing the biomedical risk factors for these patients. So I've got a little process of the health assessment at the end. So when we get through past the heart health check, I've got a little, I guess, a step-by-step on how to do the health assessments. So those top 3 assessments are the main ones that clinics will do. Depending if they service the residential aged care facilities, that's another health assessment. It's usually done on admission and then every 12 months. For the patients that have an intellectual disability, that's an every 12-month assessment as well. And some people might know that as the CHAP tool, if you've ever had to do one of those. The humanitarian entrants and refugees and the former members of the ADF, they're both the one-off health assessments as well. So depending on where you're working in your patient demographics, you might not have, I guess, enough patients to go, okay, I'm going to really work that as a target group. So this is where it becomes really important to look at your patient demographics and just see which groups that, will be the priorities for you to target. So if the patient does not identify as Aboriginal or Torres Strait Islander and they don't meet the criteria for the time-based, or as an example, they might have actually had, as an example, the 40 to 49 at age 42, and they can't have the 45 to 49 until they turn 45. So what are we going to do with those patients? So if we've done that 40 to 49 today and the patient's actually 42, I would actually rebook them in 12 months' time to come back in and have a heart health check. So we could actually get them into that rhythm of preventative healthcare appointments. So I actually think that the patients have a different, I guess, frame of mind when we're actually booking them for a health assessment like that. So they come in, I guess, open to change and looking at their risk factors. So as I was saying earlier, I think if you work this right, you could actually do a health assessment every 12 months. If we started with the over 30s for the heart health check and then worked our way through doing a combination. So the Aboriginal and Torres Strait Islander patients, it will always be the top pathway. It's just the bottom 2 groups of patients that don't identify that we'd be deciding whether they'd qualify for a time base, and if they didn't, we'd try a heart health check. So that's, I guess, the main pathway. Let's look at the heart health check. So some clinics are doing these. A lot of clinics were saying after Shane warned that they had a lot of patients actually presenting and actually requesting these health checks. So it's something to think about whether it's something your clinic, obviously has the resources to take on, as well as your other health checks. Let's have a look at the little Medicare descriptor. because you will need to have some considerations for this patient workflow. So there are some clinics that just aren't doing this health check at all. As we said, financially it's $75.75. Some clinics it's just the GP. Some clinics it's, you know, a mixture of the nurse and GP with those combined appointments. So now that that age group has decreased, so it was 45, so it's gone to the 30 years and over. It's a attendance item, so the general practitioner for at least 20 minutes. And everything else in there is, I guess, standard to what we would normally do in a 40 to 49, 45 to 49. It's, you know, collection of that information, taking the patient history and the basic physical examination. So I've, I guess, underlined because they've specifically asked for blood pressure and cholesterol. So for this health check, you might want to consider what you want to do with the workflow for the patient, from whether you want to identify that they're eligible and get them to have the blood test and then come back and book back in with the nurse and GP. Especially if you're going to be targeting some of those younger patients, you might not have some of those levels yet. So it's something to decide before you get going in these ones, because it will come up. Some clinics will do the ECG as part of that. Some will order it with the bloods. It's just really different from clinic to clinic. So as I said, try and think about it like that annual health assessment if you want to work these into your regular with the other health checks that you'll be doing. So, you know, if you want to rebook those patients every 12 months, that's what we're looking at for those. So I've put the little criteria in that flow chart. So down at the bottom of that little flow chart, I might just go back one. So down in that bottom section next to the 3, so I've got that the patient, they're over 30, they do not identify as Aboriginal or Torres Strait Islander, and they haven't had another health assessment in the last 12 months. Okay, so that's the main criteria I've got for those ones. So we went through the workflow. Like the other health assessments, I guess in the explanatory notes around the billing, it's got that the GP should not conduct a separate consultation for another health-related issue in conjunction with the health assessment unless it's clinically necessary. So they say, i.e. that the patient has an acute problem that needs to be managed separately from that assessment. And the only exception to that rule is if the patient's having the CMA in the residential aged care facility. So that's the only exception to that one. Now, I've got some steps, just generic steps you might want to add or take away from these. But for me, that actual process, like I had in that first slide, the actual process of getting the patient in and that item completed is the same as what I would do for a care plan or review. So it's all about setting, I guess, the clinic up ready. So your appointment types, what are we going to do for appointment lengths? How's the patient going to get in? And then once they've arrived, it's all about that process from the clinical team. So we're going to open the patient record. I still like to do that before you see the patient steps. So actually popping a text shortcut into my notes and then working my way through that before I call the patient in. So I try to take a couple of minutes. That way I can have a look through the record and see, you know, any red flags or anything that I need to action straight away. And then that way I engage the patient a little bit more because I'm not actually just staring at the computer and trying to type while I've got them there with me. So we're going to be doing the same thing. So recording observations, updating everything from allergies, family history, social history, smoking, alcohol. Some nurses or health workers will also update the past medical history, have a chat with the clinical team to see if that's something that you want to add in there as well. And then, like we were talking about with the care plan and review, we actually put together a list of all those prevention, detection and management activities that need to be completed over the next 12 months because we're going to need to break those up. So when we put all of that into the document, we usually save that as a draft. The GP will review that, finalise the billing, and then that's when we look at those next appointments. So it's great if you actually need to book the patient in, that we actually get that done with reception before we let them leave, because it actually does increase their attendance rate for that appointment. So that's a basic pathway. We've got a more detailed step-by-step in our manual with some more information, but that's a basic step-by-step if you wanted to have a look at that. Some of the prevention and early detection activities that we'd look at, and some of them you're already doing. So just even recording an observation like a blood pressure or heart rate as an example, peak flows, blood glucose levels, urinalysis. We're already doing those activities. We might recognise that the patient's due for certain things like immunisations or some of the cancer screening that they might be due, or have never had, some of the diabetes risk, cardiovascular, some of the social emotional wellbeing screening tools, COPD screening, chronic kidney, cognitive screening, and then the sexual health screening as well. So I've got that list there, and then this is just, I guess, a little snip from our manual. So our online version of the manual actually has all the links to the specific screening tools or guidelines in there. So I guess I would refer you guys back to Health Pathways, because it's very specific to your area. And then I've got links to the guidelines as well. And if we've got time at the end, I'll show you those today, just some of the RACGP guidelines for preventative health. The third little thing that we're going to look at as the top tip is to prepare ourselves. Like, it's a big task to kind of get this up and running. And that's why it's good if, you have those groups that are already coming into the clinic, like for the 715s or the over 75s already, that those patients get rebooked. And then you can actually take that time that you would have spent recalling them back in on the next group of patients that you need to target. So the third step I've kind of popped there, that, allocating tasks to the practice team. As I said, I like to split these into clinical and admin, and it just helps make those pathways and tasks really clear of who needs to do what. To create some of those tasks as quite small tasks, and then meeting regularly just to see where the team's up to with those. So I've got things like text shortcuts. So because there's 11 different types of text shortcuts, it's a really good thing to have those set up and ready to go. So I'm actually just going to show you quickly in best practice. So all of mine are down there in autofill. You can see I've got a different text shortcut for every different type of health check. So that's why my process becomes very similar, because regardless of the activity I'm doing, that's always my first step. Okay, the templates, while we're in this little section, the templates is also something to look at. And I guess we'd rather be spending more time with the patient, less time on paperwork. I'd rather spend less time on paperwork all the time, but we want to make sure that we're as efficient as we can be, and we don't want the document to take longer than the appointment did. So having a look at what templates you're going to be using, there's always different options. So best practice, you've got the enhanced primary care section. If you do use that, there's actually the health assessment section. Now we can use this for only certain types of health assessments. So the over 75 patients, 45 to 49, or the Aboriginal and Torres Strait Islander patients. So you'll notice it's just greyed out. So I've got this patient set as 31. So you can see they're just greyed out for that age group. So it's a really good idea to think about if you're going to be targeting some of those younger patients for the heart health check, that you have a template. So that's why it becomes easier if you just have a process like using the autofill. So this one's for the heart health assessment, and I have a generic template over here that I would use for whichever health assessment I'm doing. Okay, so it's just very basic. You can make it a lot prettier. And I've just got a custom field that lets me select which health assessment I'm doing today. So some clinics use a different template for each health check, and that's fine. just as long as everyone knows what that process is. Okay. So same in medical director, you've got options for different templates. So I'll just show you one more in BP before I switch over. So I've got the Australian Defence Force one there as well. So there's actually a specific one there for the Defence Force. And if you haven't seen that one before, they've got specific areas that you might not have seen before. So on their ADF history, they've got in the mental health, the K10 and the PTSD screening and substance use. So you might not have seen those laid out in that format before. So that's worth having a look at. For those clinics that are using medical director, there's a couple of options as well. So most clinics will use like the health assessment for their over 75s. You've also got the Aboriginal and Torres Strait Islander health assessment there and the ADF. So some clinics will use that wizard type assessment, and then some clinics will actually use the letter writer. But again, same process. I would still use the comment, which is my text shortcuts, to actually pop that information in first, and then up into the letter for those health assessments that I can't actually do up in the wizard. Okay. Now, Communicare is a little bit different. Especially with the 715, you'll be doing that in the checkup section usually, but I still prefer a little text shortcut. So I would probably crop what I've got in the text shortcut document that I've made available, just to line up a little bit better in Communicare. That would actually make that a little bit shorter. And there isn't a generic health assessment in Communicare. So the 715 health checks are fine if you're using the checkup tab for that, and the clinical items that are set up are ready for those. But for the patients that don't identify as Aboriginal and Torres Strait Islander, you're going to need a generic health assessment document to be able to complete those health checks. And you might prefer to do that as a, set up a clinical item, or if you want to set that up as a letter document. So yeah, text shortcuts and templates, really important. Ordering of resources. So what I've got in that, and because I've got a little bit of time, I'm just going to show you, because we're going to be addressing a lot of things with patients that are similar. So things like lifestyle, diet, exercise. It's a really great time to look at what resources you have in your clinic. So the ones I've got there, just up on the screen, I've got the Eat for Health website. You can actually order resources into your clinic for free. And I quite like it because it doesn't specifically say a condition on it. So it doesn't say, diabetes or anything specific on there. So there's things like an adult brochure, there's pregnancy, there's child brochures there as well. And it's got things like serving sizes. So I like to use things like that as a little worksheet. Some of the other things that they've got on their website, a lot of you would have seen the healthy eating poster. They've also got one for Aboriginal and Torres Strait Islander healthy eating guide. And the actual A4 size is double-sided. So it's actually got like a little worksheet, or I use it as a worksheet, little worksheet on the back to look at things like healthy snack ideas and things as well. So you can get the guidelines and other things as well. It's just worth, I guess, having a look at what resources you have when you're starting to get all of these things ready to do a number of health assessments. Okay, so next little bit. With the campaign materials, what I mean by that is, how are you going to, I guess, try and target patients? So some clinics will do cold calling, like trying to get patients in just by phone. Some will do like SMS campaigns. Some will generate letters and try and get patients in. Checking the eligibility, who's going to do that and when. As we said in previous sessions, I actually prefer to do that as before the appointment. So that way we can target patients more opportunistically as well. So we would usually check the eligibility for care plans and health assessments for the booked list the day before. And then we're actually going to have to create those different appointment types and links. And the other thing to consider, if you do have internal allied health services, if you're going to start using both referral pathways for the allied health, so under the care plan and under the 715 and under the diabetes pathway, you might want to consider different appointment type symbols to help with your referrals and billings after. So the last thing that I just want to mention as well is to, I guess, report what you're doing. So what I mean by that is, you know, each month run a report, see how things have improved, you know, from when you first started, because a lot of these changes are usually small. So it's, you know, something that some clinics will do as a QI activity. For those that aren't registered for the PIP QI, it's something to look at. You might want to run a report and see what you're sitting at with your MBS numbers for the health assessments and put a plan in place to try and improve that. The last little thing I'll just show you is the sources of more info. So I've got the main guidelines there from the RACGP, so the different preventative guidelines available. One of the ones I've also got there is the SNAP guidelines as well. So for those that haven't seen that, if I've got time, I'm going to leave these last few minutes for questions, but I'll bring it up in the background so we can have a look at that while we're waiting for questions. And then just before I finish, that next webinar is on the cycles of care for the clinical staff on the 8th of June, not the 8th of June, 21st, I think it is, isn't it? I haven't changed that one. So that one, yeah, 21st of June, and then the 22nd, I think, for the admin team as well.
That's correct.
Yeah. All right. Any questions?
There are a couple of questions here. So the first one is around the heart health assessment. Is the ECG time included in the 20 minutes of the heart health assessment?
If it's just the GP during the appointment, then it's the GP 20 minutes. It's not like a split time with the nurse or health worker, if that makes sense. So it's up to the GP. So yeah, I would be splitting those tasks. So for me, I'd still probably want the help from the nurse or health worker and the GP. And I know that it's only that $75, but it kind of works itself out in the end, especially if we look at it from that big picture of the over 30.
Thanks, Jane. And the second question is, do we need to scan the heart health assessment with the GP signature back into the notes?
It should be as part of the clinical software anyway, or you want the signed copy. Some clinics do that with the signed copy. It's up to the clinic to decide what they want that process to be, but it doesn't specifically say a signed copy. Let me just bring up Medicare and it just says that retain a copy. I'm pretty sure. Is this for the heart health check or any specific?
The heart health assessment. Yep.
I'll bring that one up. Pretty sure it just says retain, something like that. Copy should be retained for 2 years, like the other activities that we do. And I can't see that it specifically says signed. I know that some clinics do that with the care plan and the health assessment. They'll sign it and kind of scan it back in. Yeah, I can't see it in there.
Great. I hope that's
pretty sure it doesn't say it yet. I don't think it says it in the main one either.
Great. So that's it for questions. So if there was anything else you wanted to share with the group.
Yeah, I did want to just mention quickly, just with the health assessments for that 40 to 49, 45 to 49, the best, I guess, effect that I've had getting patients back in for those health checks is targeting a very specific time of year. So I try and target that time just before Christmas. I call it bikini ready weather. So that magical time, you know, September, October, before everyone gets too busy with Christmas. So targeting patients in that 45 to 49, 40 to 49 and heart health check, 1 and 2, because they're usually, you know, kind of keen to get ready. And then targeting just after Christmas. So that January, February, March is a really good time as well, because I guess a lot of people are, you know, focused on health as a kind of a new year, new them, that they're going to kind of be healthier that, you know, the next year and lose weight and things like that. So they're usually focused on health at those, I guess, periods of time. So I do like splitting up the target groups for different times of year to help line up with those. So yeah, they're the main target ones. The heart health, it's good to line around that. I think the February Heart Week, there's something in October as well. So just looking at that preventative calendar and what would work well for your area as well.
Thanks, Jane. The session today was really relevant and very interesting. And it's interesting, I did note down your top tip about looking at the health weeks for targeting, so not to overwhelm the practice with all the patients. And, you know, I really do like that tip, so thank you.
Yeah, it is a lot to do all in one go. It's impossible.
Okay, we don't seem to have any more questions at this stage, but I'd just like to thank everybody for joining us today. We will be sending out an evaluation form, which we would really appreciate that you send back, so that, you know, we can provide our feedback to, you know, to allow us to give you guys more webinars, because it's been really useful tool, particularly around the MBS item numbers. So yes, again, thank you, Jane. Julie, did you want to add anything else?
No. Just if you had more than one person in the room, if you could send the link out to the evaluation to those people that were present in the room, that would be lovely. I've just got a note here saying it was very informative today and looking forward to the links. Thank you. That was the Bunyara team. No problem. Thank you.
Just quickly before we finish up, the SNAP guideline I'll send through, I think it's really good. This is a really great way, especially if you're new to chronic disease management, working in primary care, because these things in that SNAP guideline from the RACGP is something you're going to have to do with every single patient. So it's not just a one-off, it's every single patient that we're going to need to look at this. So it's really good. And you might want to consider drafting something that matches the services available in your area. So use health pathways, look at what's available in your area, whether that's internal, external services, and where do you refer these guys to. So those steps 4 and 5 for each of those: smoking, overweight, poor diet, hazardous drinking and physical activity, it's really good to actually make that very detailed, and that will help onboard clinical staff or staff that are kind of new to working in primary care.
Wonderful.
That's it. I'll stop talking now. If there's any more, please let me know.
Yeah, we've got some people online that are wanting access to the PowerPoint presentation. We will be sending that out in the next few days, along with a link for the survey as well, the evaluation, that is. So thank you again. Thank you, Jane and Jane. And we'll be back on deck with the admin or practice managers and the clinical in the coming weeks. So that's in 2 weeks' time, on the 21st.
21st, yeah.
Wonderful. Thank you again, all.
Thanks, everyone.